Hello, I am Thomas Farrington, President and founder of PHEN. I am pleased to welcome you to PHEN's 17th Annual African American Prostate Cancer Disparity Summit and to our Session 3, Enhancing Early Detection, Treatments, and Clinical Trials Education. I really want to thank our audience for joining us today. We're so happy to have you with us. And I want to acknowledge and thank our sponsors for their support. For those of you who missed Summit Sessions 1 and 2, I want to let you know that they are recorded and available to watch at phensummit.org. At PHEN, we feel strongly that knowledge is the best defense against prostate cancer. Today's session will focus on strategies that we use to enhance patient education for early detection, treatments, and clinical trials. I want to get the session off the ground and moving. So at this point, I'm going to introduce our Director of Clinical Trials and Patient Education, Dr. Keith Crawford, to moderate the session. Dr. Crawford.
Thank you, Tom. First thing I want to do is really thank the audience for being in attendance. Thank you for the kind words, Tom. And also I wanted to acknowledge our network members who have provided information and helped contribute in the development of all of these tools that you'll learn about. So now, I'd like to go to our slides, and that should be coming up pretty soon. Okay. The next slide, please. The objectives of this session are broadly discuss the problems of prostate cancer disparity as it relates to screening, treatment, and clinical trials. Now, you will hear from patients, caregivers, providers, and learn about their experience and hear suggestions which could help alleviate healthcare disparity. And lastly, we'll review PHEN tools and resources which can help patient, caregivers, and providers overcome the barriers to equitable prostate cancer care. Next slide. Now, PHEN's mission, and this is a very important point I would like to bring out. Our objective is to eliminate African American prostate cancer disparity and to undertake advocacy efforts to increase the overall support of resources to wage a war against prostate cancer that will eventually lead to the cure for the disease and the benefit of all men. So keeping it short, we want to decrease the disparity gap, close it for African American men, and also be a benefit to all men. And as you know, PHEN was founded in 2003 by Mr. Thomas Farrington, who is a prostate cancer survivor. And Tom always likes to give us messages to kind of get us fired up, to get us thinking about why we're doing this. And one of his messages is we are facing an unprecedented prostate cancer crisis in the country, and Black men will be hit the hardest. PHEN is raising prostate cancer awareness throughout Black America and providing educational resources to address the disparities in early detection treatment and clinical trials. Next slide. Now, and this is something that's very important, and this is what we want to alert everyone to. There will be new cases of prostate cancer in 2021. The American Cancer Society estimates over 248,530 new cases of prostate cancer. Now, the number by itself doesn't give you an idea of how impactful this increase is. But when you recognize that that number is a 30% increase in prostate cancer cases and the largest increase of any major cancer, that hits home. Now, the American Cancer Society also states that when you look back earlier and you looked at prostate cancer screening, PSA testing, and advances in treatment, it helped lower the death rate for prostate cancer by 4% each year from the mid-1990s to 2013. But more recently, and this is a focal point because Mr. Farrington has been talking about this potential impact since 2013. Between 2013 and 2018, the death rate is no longer dropping. It's increasing. Next slide. So we state a problem. We don't harbor on the problem. Now it's the time to make a difference, to make a change. So recognizing that there's a need for early detection screening and recognizing that the CDC has said that the early detection, the longer your life. There's a need for us to then educate men, African-American men, about screening, early detection screening. And so we created a portal called PHENPSA.com. Now, I want you to, you'll recognize the theme as you go through. We keep everything simple, PHEN PSA for screening. Next slide. Now, if you were to go to this portal, we try to make it easy for the patient and also for the patient to use with the clinician. The portal is not something that you have to, it's an app that you have to download. It's something that it's on your phone, it's on your tablet, it can be on your computer, it can be on the clinician's desk, and both of you can sit and look at it and understand and answer these questions. So we group it into categories that try to, next slide, address questions. What Black men need to know. Now, I asked the question, or Doc PSA asked the question, did you know that prostate cancer is the leading type of cancer for Black men? Did you know? And so with PHEN PSA, our screening tool, it will answer each one of these questions. It will educate the patient so they can sit down and have a discussion with their physician and talk about starting screening. Next slide. Another question, why should Black men be especially interested in early detection screening? And again, you got to talk to your doctor about your risk. But these 5 points are extremely important. Prostate cancer is the leading cause of cancer among Black men. And I highlighted again, leading cause of cancer among Black men. All African-American men are at high risk of being diagnosed and dying from prostate cancer. Approximately 1 out of every 5 will be diagnosed with this disease. Black men are diagnosed at a rate 77% higher than white men, and then die at 120% higher rate. This is the largest racial disparity of any type of major cancer for men and women. And I say it again, the largest racial disparity for any type of major cancer for men and women. But prostate cancer is curable if detected early. Prostate cancer 10-year survival rate, when detected early, is more than 95%. Now, this is straight from the CDC. Next slide. Now, in PHEN PSA, in the tool, there's a lot of information. There's information there for the patient, but it's also information there to help you have that discussion with your doctor. Now, the question is when to begin, when to stop, and really, how often do I need to take these screenings? Now, PHEN adheres to the most aggressive guidelines and recommendations. But at first, we wanted to give you an idea of the top organizations that discuss and provide guidelines about screening. American Cancer Society begins age 40, stop age 70. The frequency, how often you're tested, every 2 years. Now, the American Urological Association also says 40 and stop at 70, and then every 2 years, but then reference that African Americans may need be screened more frequently. Now, we adhere to the National Comprehensive Cancer Network, and they suggest 40, and then they let you know that African American ancestry and germline mutations need to start at 40. But they expand the screening and it should stop at 75. And the screening frequency is every year. And lastly, the United States Preventive Medicine Task Force suggests greater than 55 to begin screening, but they did mention that Black men are at high risk and you may want to start earlier. The stopping year is 70, but they're still looking at 2 years screening every 2 years. And they just said that they don't really have a lot of information for African-American men. But if what we adhere to is the National Comprehensive Cancer Network guidelines, age 40, start, African-American history, germline mutations, and stopping at 75 in every year. Next slide. Okay, so I would like to stop here. And what I'd like to do is bring in our panelists. Now, our first panelist is Dr. Wasim Hussain. He is Associate Regional Medical Director of Primary Care at Luminous Healthcare Systems. Hello, Dr. Hussain.
Hello, everybody. Hopefully you can hear me.
Yes.
Thank you very much for that great talk so far. I'm part of what we practice, basically our large regional healthcare system outside of Washington, D.C. And we've joined the PHEN network to basically begin a screening program to capture as many PSAs as possible amongst a population that generally we see a very big healthcare gap in. The way we've begun to do it, the way we begin our program is to utilize and leverage the power of our electronic medical record system. We run a system called EPIC, and one of the key pieces of the plan to improve screening is to introduce this concept of a best practice alert into the system, so that any provider who's seeing a patient that falls into that high risk group, and we have also adopted the high risk, we've adopted that some of the recommendations from PHEN PSA, where if you're African American, if you're a man, if you're between the ages of 40 to 75, that is going to flare up whenever you see the patient as an alert that this patient needs a PSA or this patient is behind on their PSA. And then the doctor can take action during any visit, be it a phone visit, a message, or the actual in-person face-to-face visit, to go ahead and order that PSA and make sure it gets done. So we've introduced that program towards the end of June, beginning of July. And our hope is that in the 3 pilot practices that we have begun this project, that we're going to see the rates of screening improve significantly. Our baseline right now, before we joined the program and before we incorporated some of these PHEN principles, is basically we were only capturing about 1 out of 3 African American men who needed to have prostate cancer screening. So we really want to see that number improve. We should get our sort of first preliminary set of data towards the end of October, and we should see that number consistently improve over the course of the year. And if it's successful at the 3 pilot sites, then we should be able to expand it to all of our clinics. In our network, we have about 70 physicians altogether, scattered basically in suburban Maryland. But we've begun the pilot project initially in these sort of suburbs that are right outside Washington, D.C. So that's probably the single most exciting thing that we're incorporating. We've also, through the grant, been able to get a lot of patient education materials and educating our providers that when they see patients at routine physicals or at any time where they feel like this is a good time to discuss prostate cancer screening, that is done. And we have handouts to give those patients. We have the website referrals to give those patients. When we order the PSA in the system now, the patient automatically gets a link to the PHEN PSA site where they're able to go after the visit and read through the detailed slide presentation that's on there that answers some of the fundamental questions that Dr. Crawford was presenting at the beginning of the talk. So really excited to see it work. We're just getting started here, but we're off to a great start, I would say. And we'll keep you posted on how all things go.
Thank you, Dr. Hussain. I had a couple of questions that I wanted to ask you. And,
Sure.
And the first was, does it save you time? So when you're having these discussions with patients, and does it save you time when you talk about screening?
Sure, absolutely. Like, it certainly saves time in the level of detail that this topic deserves. And as everybody in primary care knows, time is very precious. We've got like 15, 20, 30 minutes with the patients at the most. So it's fantastic to have the website as a resource to be able to say to the patients that here's a pamphlet, here's the web address. There's so much more that's behind some of the preliminary sort of starter conversation that we're having in the clinic. And so ultimately the patient becomes very educated in the topic of prostate cancer and the importance of screening. So absolutely, yes.
What did some of your colleagues say when they were introducing?
So they found the same sort of principles to be true. I think fundamentally, the biggest thing that we're seeing is an increase in PSA screening. So it's very helpful in the course of like a typical primary care visit where you're literally talking about a dozen different things, that you have a big flashing thing on the monitor that says, check this patient's PSA. So I would say that on a practical level, that's probably been the most positive outcome that's come from it. That's what I've heard from my colleagues. Because it's not at front of mind for a lot of the physicians who are not used to doing regular PSA screening. And this is a valuable tool to bring it to front of mind.
Mm-hmm. When we take a look at the guidelines for screening, how helpful was that table to the clinicians to have that information right in front of them? Say, okay, I know who NCCN is, or American Cancer Society, or American Urological Society.
I would say on the website, from a physician perspective, that single table is probably the single most valuable part for most physicians. I can certainly say it's the most valuable part for me because, as you all know, it is a relatively controversial topic and it gets fuzzy around the edges. Like, when do you start screening? When do you stop screening? Different societies say different things. The frequency interval is different among different societies. So it's great to see it sort of all laid out like that, sort of almost like a meta-analysis is what it sort of presents. And it's a fantastic way to help sort of, at the end of the day, these are guidelines. And like when you see it presented that way on multiple levels, it really helps organize the physician's thoughts on, does this person fall into those guidelines? Do I consider that person high enough risk to begin them at 40? And so there's some really valuable information there because it's such the guidelines themselves are so fuzzy across the board. It's great to see a concrete slide like that spells it out for everybody.
Okay. And then I wanted to give you the last word. I know you have to run. What would you like to leave our audience with? Because we're introducing, the whole country has access to PHEN PSA. And what is your closing thoughts?
So I think that the first thing is to just fundamentally increase awareness. Like, that's the absolute most important thing because it's not on the front of a lot of patients' minds. And there's a lot of stigma when we're talking about genitourinary issues amongst men as well. And to just kind of make it part of a natural conversation and have resources that are very easy to access. That's what PHEN PSA fundamentally does from the patient-facing side of the website. And then certainly from the doctor-facing point of the website, we've got that great list of guidelines and sort of the importance of really zoning in and being more aggressive with our screening because of the last 20 years, the guidelines that the United States Preventative Task Force put out there, like that's done a disservice, I think, to the general population. It's sort of decreased in some ways the intensity and aggressive strategies that we had in place to screen for prostate cancer. So we want to see that pendulum swinging back in the right direction, not just amongst the population, but amongst primary care physicians and the group of physicians that does do routine PSA screening.
All right, thank you, Dr. Hussain. And
Thank
we
you.
really appreciate it. And we're looking forward to that information at towards the end of the month.
Yeah. We
We're
really
happy
want to
about
see,
it.
we want to see
Yes.
those screening rates going up, and we want to be able to.
We want to see those screening rates go up. That's exactly right. And thank you again. And we'll talk soon.
Thank you so much, everybody.
Okay. Now, I want to transition from Dr. Hussein to Dr. Angelo Moore. Now, Dr. Angelo Moore is a program manager at the Office of Health Equity at Duke Cancer Institute. Now, Dr. Hussein gave you the perspective from the clinician. Now, Dr. Angelo Moore is going to give you the perspective from the nurse. Now, that's a different lens, and they interact with the patient differently. So, could we bring in Dr. Moore?
Yes, good afternoon, everyone. Glad to be here. Yes, I would like to say, PHEN PSA has been a great program. We're actually have a QI project going on right now where we have implemented PHEN PSA and how we communicate with patients. So for instance, with this particular program, individuals for this project, looking at African-American men with elevated PSAs, we have community-facing navigators who reach out to these men. And because one of the things we found is there's been a lack of follow-up once an individual gets a referral for elevated PSA, and they're not necessarily getting to a urologist for the diagnostic follow-up that they need. Mm-hmm. And so what we have done, we've instituted PHEN PSA as an educational tool to be able to increase their health literacy when it comes to prostate cancer screening. I always tell them, it's important to have knowledge and information because that's how you're able to advocate for yourself. Like Dr. Hussein indicated, when you're seeing a primary care provider, everything is so quick. They might necessarily think about screening for prostate cancer, but as an African-American man, you need to know that, hey, I'm at high risk. I need to ask, I need to be screened for prostate cancer. And so we want to make sure that individuals are equipped, and PHEN PSA is a great opportunity for men to learn about what is a prostate, what is a PSA, what is considered normal, how often you should screen for it, because this is how we can increase the number of men that's being able to be screened for prostate cancer.
So could you tell me about the type of patients in your practice?
Yes, the individuals in our practice, I work for the Duke Cancer Institute. So, looking at primary care, we have all types of patients, but a lot of patients that we focus on in community-facing navigation are individuals who do not have health insurance or are underinsured, even though we work with people who have insurance as well. And so we work with all individuals, but specifically, when it comes to prostate cancer, the African-American men are the ones that we really focus on with the screening.
Mm-hmm. Now, you mentioned a little bit earlier that you have a navigator program. So that's different than in the case of the Luminous group, where the patient's coming there, but now you have a specific navigator for patients. And how do the navigators, what do they think about PHEN PSA?
Yeah, the navigators, they actually love the PSA, PHEN PSA, because, they're able to, because we're doing a lot of things virtually now, they're able to log on the system and actually go through, gives them a nice guide to make it more standardized of the information that they provide in patients. You take it step by step, and men have the ability to go back, and review on their own and actually review with their family members. So it's a great resource for them to have.
Mm-hmm. Is that some of the comments that you're getting back from some of the patients?
Yes, some of they actually enjoy being able to have access to this information, and not only to PHEN PSA, but all of the educational tools that's on the PHEN network. When it comes to the Daddy's Boys plays, the recordings, looking at treatment options and how to understand that. It's just a plethora of information that's really focused and targeted for African-American men. And so almost every African-American man I come in contact with, I tell them about PHEN Network. It has so many resources.
Well, thank you. Thank you. Thank you very much. We appreciate that. I mean, it is impactful, and it's nice that it transitions from the clinicians to the nurses to the navigators. And that's extremely important. So is there any tidbits, any information you want to say, if you want to tell the audience else about your experience or about PHEN PSA?
Yeah, I would say that, education is really important, because we're dealing with, a population that the health literacy may not be as high as what a lot of educational things that we have in our health system. And so giving them access to this information is really important to help equip them to be advocates for themselves. And we have to be able to advocate for ourselves, and having the ability to go back and share this information with your family members, to be able to understand this before you get a diagnosis of prostate cancer. When a person gets a diagnosis of cancer, their world is turned upside down. So it's really important for us to know beforehand, what are some things that we need to do, when we need to screen, how do we do the screening, what does it mean? So you can ask appropriate questions to get the best care possible for yourself.
Thank you. And one other quick question. And there are these guidelines that exist, and you see how we summarize the treatment guidelines. And now, it is helpful for the patient to understand the guidelines, but have you showed your colleagues these guidelines, and do you have any feedback about those guidelines?
Yes, those guidelines are very important because the two big studies that came out in 2010 created a lot of confusion, along with the recommendation of the preventive task force. And so being able to see very succinctly in one location, what are the recommended guidelines, when you should start screening. I think that's one of the most important things, is when to start screening, at what age, and then how often you should screen. Those are the two most important things to me. But that actually gives you clear guidance on who you should screen. And so that's been the feedback that I've had, is very positive, great, like Dr. Hussein said, everything in one location. And if you notice on the guideline, 40, 40, 40, 40, that's what I keep in mind, 40. That's when we need to start screening. That's an easy number to remember.
That's an easy number to remember. Easy number. And thank you. I want you to stay on. And then what I wanted to do, I have one of our network members, Mr. Battle, Rasan Battle, and he is a survivor. And I wanted to bring him on, and I wanted him to tell his story.
Good afternoon, everyone. Thank you, PHEN, for having me. So my journey started out in 2018, and I want to preface this by saying early detection is the utmost importance, and education, knowledge is power. And I wish I had known PHEN in 2018 prior to my diagnosis. And so I'll go back to when I was 40 years old. I began to feel different. I don't know how to explain it, but I didn't feel normal. And I started having some minor pains in my side, and just my system felt off. And so at that time, I was an avid going to the gym a lot. I was in very good shape. And so when I went to my primary care doctor and explained what I was feeling, the type of symptoms I was having, he told me it was digestional. It might have been dietary. And I have a very strict diet. And so I didn't think that was the case, but obviously I followed my primary care. And the symptoms continued. I went back and I actually asked him, I said, there's something going on. Is it possible to get checked for prostate, or if I can get scoped, endoscopy or colonoscopy, either one. I just wanted to check out my insides. And at 40 years old, I was told I'm too young, I'm in great shape, and there is nothing wrong with me. And so I continued for the next 5 years, trying to figure out what was going on. And so in October of 2018, I was at work and I began to, over the past few days, I had become very lethargic. Going upstairs, I found it very hard to recover. And so I ended up in the emergency room with a lot of stomach pain. And actually, I went to my primary care first, and he did a stomach exam by pressing and so forth. And he told me he thought my appendix was inflamed and about to rupture, and that I needed to go to the emergency room. At that time, I went to the emergency room and they ran several tests. And after maybe 3 or 4 hours, the diagnosis came back that I had actually had stage 4 prostate cancer that had metastasized all over my body, in my bones, and that I needed to come up with treatment options. As Dr. Moore mentioned, when you have a diagnosis of that, your world is tipped upside down. And I was extremely fortunate to have a very good friend of mine, Dr. Keith Crawford, in my corner, who I reached out to. And that's when I was introduced to the PHEN network. I began to go to meetings. I began to receive an enormous amount of education. And one thing I can say that PHEN did is they as Dr. Moore again pointed out, is giving you the courage and bravery to become your own advocate, and the importance of speaking out for your own healthcare and wellness. And so with PHEN's help and guidance and education and network, they've given me the strength to go and fight and battle this cancer. And so unfortunately, recently in the last 5 weeks, my cancer has returned. It was in a dormant state for the last 2.5 years. And so once again, I reached out to Dr. Crawford and asked him, some advice and some resources. And yes, my medicine is no longer working. And so they gave me options of switching other medicines and some trials as well. And so Dr. Crawford was kind enough to meet with me over dinner and go through everything the doctors had given me and discuss all my treatment options. And so here I am today, a survivor, still fighting a good fight, and very gracious and thankful that PHEN has an amazing network of colleagues, of information, of early testing, and just a wealth of information, knowledge, and support. And so I'm grateful to be here, and I just want to say thank you to PHEN. Thank you to all the men on the board who educate and fight this good fight daily. Thank you.
Thank you, Ross. Thank you, Ross. And what I want you to do is, and this is very important because you had mentioned that your PSAs come back, your cancer's recurrent, and I think you had mentioned that there may be some evidence in a hip. But now I wanted to bring on Jacob Burchak. He's a medical oncologist from the Dana-Farber Cancer Institute. And see, Jacob is at the front line at the Dana-Farber. And he's going to go over all the potential treatment options that are available. So this is going to be a benefit for you. And we're always here and we're ready to discuss. And we'll always go back to our next tool, which I'll talk about after Dr. Burchak gives his talk.
Great. Well, thank you so much, Dr. Crawford, for the introduction. And I'm going to share my slides here. while I'm pulling that up, I just wanted to say how honored I am to have the opportunity to speak on behalf of and be a part of such a important organization that's doing such amazing work. And so, as Dr. Crawford mentioned, I'm a medical oncologist at Dana-Farber Cancer Institute in Boston, specialize in the care of men with prostate cancer. And my contact information is there, and I'm always happy to be in touch with anyone who I could help. So please feel free to reach out with any questions, either about this talk today or otherwise. And I'm also a prostate cancer researcher focused on developing liquid biopsies for cancer detection and better understanding prostate cancer genetics and epigenetics, with interest in improving our understanding of prostate cancer racial disparities. So throughout this talk over the next 20 minutes or so, I hope to give an overview of the treatment across the prostate cancer disease spectrum. It's a disease with many different stages, and treatment really depends on the stage that a patient has. And so I'm going to touch briefly on localized disease. You know, as we've discussed so far, the goal is to detect the cancer using PSA and other tools when the cancer is localized, when it's confined to the prostate, when it's curable. Generally speaking, once it's advanced, once it's spread to other parts of the body, it fortunately in 2021 is very treatable. And I'm going to talk through lots of the different options that we have to treat advanced disease today. But generally speaking, not considered curable today. But certainly there are always exceptions to the rule, and you'll see just lots and lots of reason for hope for men with advanced prostate cancer, given the outstanding treatment options that we have. I'm going to quickly focus on localized disease, which is, as I mentioned, when the cancer is confined to the prostate, and generally when it is detected, it most often is localized. And I spent some time with Dr. Crawford last week going through the PHEN PSA and PHEN-PATH websites, and they do an outstanding job of breaking up localized disease into these different risk groups. And this is really important because it has implications for how we treat the cancer. Generally speaking, we have a few variables that we use to bin men into these different groups to determine the optimal treatment. The PSA we discussed, and the PSA level, less than 10 is low risk, greater than 20 is high risk, and 10 to 20 is intermediate. And then the Gleason score, which is a score that pathologists assign to the prostate cancer once they receive the prostate biopsy slides. They assign a score from 6 being low risk to 10 being high risk, 8 to 10 being high risk, again with 7 being intermediate. You know, we have other variables that we certainly factor into consideration for deciding which risk group men are in and the optimal treatment. On the left, that shows a depiction of a prostate, and you can see there are 12 different zones that it's divided into, reflective of that we usually get at least 12 biopsies. So how many of those biopsies have cancer is a consideration that we use. I mentioned the Gleason score. That color diagram is sort of a schema of how we assign Gleason scores. And then a new, relatively new tool, something that really has become standard of care, is getting prostate MRIs. MRIs are a type of imaging technique that gives really crisp and detailed pictures of the pelvis and the prostate, and allows us to determine where the cancer is, how much cancer there is, has it spread outside of the prostate, et cetera, and is a really valuable tool that we now use for pretty much all men with localized disease to categorize them and determine which category they're in. And as I mentioned, treatment really depends on which group men are in based on these criteria. The first one I'll touch on is active surveillance, and each one of these could be their own 30-minute talk, and so can only unfortunately go into these in very brief detail. But active surveillance is a potential option for certain men with low risk cancer. One of the results of screening, all men for PSA once they hit a certain age is that we're going to find some cancers that actually don't need to be treated, imminently. These men with small amounts of Gleason 6 cancer, low PSAs, may be candidates for active surveillance, which entails additional PSA screening over the years, repeat biopsies, and MRIs of the prostate. And really, we're looking for any sign that the cancer is acquiring more aggressive features and needs to be treated. The other standard treatments for prostate cancer, what we call definitive treatment, definitively dealing with the cancer, are surgery, radiation, and hormone therapy. You can see for low risk and some men with intermediate risk, surgery or radiation alone are good options. Surgery is really a good option across the board. Removing the prostate can be curative for most men. Once men have higher risk disease, we add androgen deprivation therapy, what we call ADT. And this is on the basis that we know that prostate cancer is addicted to testosterone. So by removing the testosterone from men's bodies with the androgen deprivation therapy, shutting off their ability to make testosterone, we're starving the cancer cells. And we know that for certain men with higher risk disease, adding this in addition to radiation increases the cure rate and long-term survival. There's a lot of nuance in this decision-making and something that's incredibly personalized for men, for each man sitting in front of us. But I wanted to sort of go over general principles. Now, again, the goal with treatment for localized disease is cure, but we know that some men will have cancer recurrence after one of these treatments. The PSA will start rising again. And some men, as we just learned, can present with stage 4 cancer when the cancer has already spread from the prostate to other parts of the body at the time of diagnosis. But this schema depicts how some men's prostate cancer course runs who recur after initial treatment. The red line here is the PSA. And as you can see, the PSA will rise after surgery or radiation and then responds to treatment. And intermittently will respond to treatment, which will, in most cases, stop working. And as you can see here, I think this is reflective where there's several periods of response followed by progression, which is indicative that we have several treatments that are used in most cases sequentially to treat the prostate cancer, oftentimes achieving long periods of remission and disease control. And so this slide, I think, provides a nice overview of the various drugs that we have in prostate cancer. I'll walk through some of these in detail and others as sort of a class, but I group them by color based on the type of treatments that they are. Chemotherapy is a class of drugs that are highly effective in prostate cancer. We have 3 that we commonly use: docetaxel and cabazitaxel, more commonly than mitoxantrone, the third one. We have radiopharmaceuticals. I'll touch more about lutetium PSMA. You can see it's sort of shaded in, indicative that it's not FDA approved yet and not available today, but we just learned about the effectiveness of it earlier this summer. And I'm going to talk about that as an exciting new treatment option that we have in our arsenal. Really, one of the backbones of treatment of prostate cancer is targeting the androgen receptor, which I abbreviate here, AR. There are 4 drugs that we use routinely in clinic. And the androgen receptor is what the testosterone molecule binds onto. And so essentially blocking that testosterone signaling and starving the prostate cancer cells is highly effective. Immune therapy is something that holds a lot of promise. We have 2 drugs that are used in men with prostate cancer, and a lot of interest in developing that approach further. And then PARP inhibitors, which are a type of targeted therapy, which again, I'll touch on a little bit later in the talk, but are an exciting new development in prostate cancer in the last few years. And then on the top, I probably should have started with this, but ADT, or androgen deprivation therapy, is something that initially we will use intermittently, lowering the testosterone level and seeing responses. But as you can see, the PSA will stop responding. And at that point, we consider men to be castration resistant. It's a term that essentially just means that the hormone therapy alone is not enough to control the cancer, and we need to add one of these additional agents. Now, there are several considerations in how we consider using these different tools, these different medications to treat men. One is, as you can see, there's several options to choose from, more than 10 treatments that we can choose from. So how do we sequence those? How do we decide what to use first, what to use subsequently? Something I'll talk about in a moment. Second consideration is optimal patient selection. Are there features that we can determine a patient's PSA level, where the disease is located? More recently, in the last 5 years or so, what mutations they might have in their tumor, what mutations they might have been born with that will predict response, the likelihood of responding or benefiting from a given treatment. And then lastly, an area that is emerging and is of great importance is what do we know about the impact of ancestry and race on the response to the benefit from these different treatments? Which ones do some work better than others in men of different ancestral background and race, and differences in the biology of prostate cancer across ancestry. And so I think that's the third point that I want to wrap up with. I mentioned I was going to talk briefly about lutetium PSMA. This is somewhat hot off the press, as you can see. Just at our meeting in June of this year is when this clinical trial was reported. Lutetium PSMA is actually, let me start with what PSMA is. PSMA stands for prostate specific membrane antigen, which essentially means it's a protein that sits on the surface of prostate cancer cells. And the lutetium PSMA drug is an antibody, which essentially is designed to target to the PSMA molecule. And then the antibody is linked to a radioactive particle. So this antibody targets to the cancer cell and then delivers a radioactive particle to kill the cancer cell. Very, very briefly, going to show the bottom line results from this study. These are Kaplan-Meier curves, and essentially they show the results of outcomes for men treated with one cancer or one treatment type or another. So these were men with advanced prostate cancer who were treated with lutetium PSMA plus a standard treatment or the standard treatment alone. And as you can see, the progression-free survival, essentially the time until men showed progressive disease on CAT scan or bone scan, was significantly longer, the blue line, for men treated with the lutetium PSMA compared to the standard treatment alone. And even more importantly, you can see the curves separate here, and men treated with the lutetium PSMA lived longer than those receiving the standard treatment. So this is another new and exciting treatment that we have in our toolbox for treating men with advanced prostate cancer. I'll caveat that it's not FDA approved yet. We're eagerly awaiting that, and I think that will be coming in the next couple months and will be widely available. The other caveat is that it did require a specialized, what we call PSMA PET scan. Whether or not that's necessary once it's approved, we're all waiting to see, but that might be something to consider because while those are available in some places, it may not be available everywhere, but we're all eagerly awaiting the results or for that to be approved. Moving on to sequencing therapies and how we think about that. We know that in some situations, sequencing of therapies, what order we give them, may matter. As I mentioned, there are two drugs, abiraterone and enzalutamide. I'll call them Abi and Enza, which are both AR signaling inhibitors. They both block testosterone signaling and the effects of testosterone on prostate cancer, and are both highly effective drugs for men with metastatic cancer. But based on some anecdotal data or some data seen retrospectively, this team designed a clinical trial to ask, does the sequence matter? Does it matter if we give Abi first followed by Enza or Enza first followed by Abi? And so they designed this clinical trial doing exactly that. Men were randomized to receive one or the other first, and when the PSA started rising, they were switched over to the other one. And in blue and red, it shows the two different sequences, Abi followed by Enza and vice versa. And this is showing how much the PSA decreased. The further this line goes down, the better. You can see over here, a couple of patients had a 100% drop in the PSA. PSA less than 30 is one of the metrics that we use to consider how effective a drug is. And you can see the men who got abiraterone first, followed by enzalutamide, had a much higher likelihood of having the PSA drop subsequently when they received the second agent. Likewise, again, showing these survival curves, we see that the time to PSA progression on the second drug was significantly longer for men who received abiraterone followed by enzalutamide. This is looking at now overall survival, the most important metric. Did men live longer or not, whether they received these in one order or the other? And you see that there's it's not quite as robust, but a suggestion that maybe men live longer, do better if they get the abiraterone followed by enzalutamide. So really intriguing data, and as you know, reflective of this, my practice is, unless there's another good reason, I will give abiraterone first and then consider enzalutamide later, based in part on these data, which suggest that it may be a more effective approach. Another example of this is a clinical trial called the CARD clinical trial that came out 2 years ago, and I think really changed how we think about using chemotherapy. This was a clinical trial of men who had received one of those drugs, abiraterone or enzalutamide, and they were asking, is it better to give chemotherapy next or to give the other hormone drug? So for example, for a man who got abiraterone first, this asked, is it better to give chemotherapy, a drug called cabazitaxel, or to give enzalutamide, the other hormone therapy? And strikingly, if you look at the overall survival, men live significantly longer if they received the cabazitaxel chemotherapy instead of the other hormone therapy next. And so, you know, looking at other really important endpoints, pain response, what proportion of men had an improvement in their pain? You can see 45% of men who had cabazitaxel next had an improvement in pain, compared to only 19% if they received abiraterone or enzalutamide next. And so I think, you know, this was another clinical trial that really informed how we think about sequencing these agents. For a gentleman who's already progressed on abiraterone or enzalutamide, in my practice, based on this data, will be, if possible, we'll give chemotherapy next based on a significant improvement in progression, in survival, and an improvement in symptoms. So you can see data, you know, it's a rapidly evolving field with new data coming out recently that really informs how we think about sequencing these treatments. I'm going to move on now to give a couple examples of how patient selection, thinking about factors that an individual patient has, the patient sitting in front of me in my office, that I can use to predict whether or not they're likely to benefit or who's most likely to benefit from certain treatments. This is a drug called Sipuleucel T, or Provenge. This is one of the immune therapies that we have in prostate cancer that we know is effective. So it's a really interesting drug. I'm going to quickly go through how it works. We take a protein that's expressed in prostate cancer cells that's unique to prostate cancer cells, and we actually collect patients' white blood cells. We send them to the lab and collect their own white blood cells, the part of the immune system that helps us fight infections. And in a laboratory, we expose the person's white blood cells to this protein that's specific to prostate cancer cells, and essentially train their white blood cells to recognize the prostate cancer, and then infuse the white blood cells back into patients, with the idea that they can recognize and attack and kill the prostate cancer cells. This trial, or this has been around for quite some time. You can see in 2010, this drug was shown in men with minimally symptomatic or asymptomatic metastatic prostate cancer to significantly prolong men's lives, on average of about 4 months. About 3 years later, though, this really interesting analysis came out where they looked at how likely men were to benefit from this treatment based on what their PSA level was prior to treatment. You can see they broke men up into quartiles: PSA less than 22, 22 to 50, 50 to 134, or greater than 134. And they show how long on average men lived in these different groups, whether they received the Provenge immune therapy or the control. And strikingly, if you look at the men with low PSA, less than 22, those men lived 13 months longer, over a year longer, if they received this immune therapy. You can see in men with high PSA, they only on average lived about 3 months longer. And the difference wasn't significant. So this is really compelling to say that men who benefit most from this immune therapy were those who have low PSA. And in practice, we apply this. I tend to think about giving this Provenge drug early in men's course when their PSA is lower, and can feel optimistic that giving this to a gentleman with lower PSA, that their likelihood to benefit is a lot higher than someone whose PSA is much higher. Now here's where I think things get really exciting. This is sort of the modern era of treating prostate cancer. These are findings that are new in the last several years and are making a big difference for some men with advanced prostate cancer. Targeted therapy. So targeted therapy is the theory, or is using the approach of understanding the molecular features of a given patient's tumor, understanding what genes are abnormal, what proteins are abnormally expressed, and then using therapies that target those aberrant molecular features to tailor or personalize treatment for that patient. And so two papers that came out in 2015 really informed our understanding of what targeted therapy options might be effective for men with prostate cancer. On the left here was from a paper a research effort where they sequenced the tumors of hundreds of men with advanced prostate cancer and asked what alterations are there in the genome in patients' genes that are recurrently seen. And one of the things that stood out is alterations in genes that are involved in DNA repair, in repairing the DNA when there are errors. And what's really exciting about this is that we have drugs, particularly PARP inhibitors, also a type of chemotherapy called platinum-based chemotherapies, that we know tend to be more effective in men with DNA repair alterations. So it suggested that up to 23% of men might have alterations in their tumors that will predict that they'll benefit from these targeted therapies. In the same year, there was a paper that looked at the germline DNA. Now, germline DNA is the DNA that we're born with. Some people are born with mutations in genes that predispose them to developing cancer, that increase their risk of developing certain cancers. Dr. Crawford touched on this when he was talking about screening. We know that men of African ancestry are higher risk for developing prostate cancer. Likewise, men with certain mutations, germline mutations, are at higher risk. The flip side of that is that we know that they've predisposed to benefiting from certain targeted therapies. And in the germline, it was about 12% of men had alterations in these DNA damage repair genes. Now, as I mentioned, we can use this information for targeted therapy. This was a clinical trial called PROfound that was published last year and demonstrates for the first time that a targeted therapy is effective in improving survival for men with prostate cancer. This was a clinical trial that looked at men with advanced prostate cancer whose either their germline DNA or their tumor DNA showed an alteration in one of those genes, and they were treated with a drug called olaparib, which is a PARP inhibitor that we know targets men with those patients with those alterations. As you can see on the left, there was a significant prolongation of how long men lived on average, 3.5 months or so, and a 20% reduction in death during the study period. Now, as I mentioned, this included about 15 men with 15 different genes in either their tumor or their germline DNA. And getting back to that question of optimal patient selection, they looked at which genes of those 15, surely not all of them act the same way. And so they asked which of these are more beneficial for treatment with PARP inhibitors, which are less. And without going into too much detail, that's exactly what they saw. They saw that genes like this PPP2R2A, a mouthful I know, but those patients actually seem to do worse with the treatment of a PARP inhibitor than the control arm. In contrast, and this is consistent with what we know from other studies, patients with BRCA1 and BRCA2 mutations, some of the most common mutations we see in prostate cancer, seem to benefit the most. And the similar studies are ongoing to try to really understand what is the optimal patient who's going to benefit most from this targeted treatment approach. And this is sort of a really exciting and interesting area of ongoing research in prostate cancer. And for my last few minutes, wanted to touch on some differences that we know that exist in the biology of prostate cancer between men of different ancestry and race. Moving along with this theme of DNA damage repair, there were two studies that came out in the last few years that inform our understanding of the rates of different mutations, these DNA repair mutations in men of different ancestral background. This was a paper published by Brandon Mahal in the New England Journal last fall where it was the first large study where they compared mutation rates across men of different ancestral backgrounds. Without going into detail, you can see there's differences across men of Asian, white, and Black background. But I think I pulled out something that I think is notable and in line with the theme what we've been discussing. They found that Black men actually had a higher rate of DNA repair mutations in their tumors, suggesting that maybe there's a higher proportion of Black men compared to others who might benefit from these targeted therapies. Interestingly, a study of the germline DNA comparing rates of germline mutations in Caucasian American versus African American men found a lower rate of DNA damage repair mutations, about 8% compared to 12 to 15% in Caucasian American men. And BRCA2, the most common gene, was lower as well. I do want to point out, you can see that in these two studies of Caucasian men, there were 600, 2,000, almost 3,000 men across these with Caucasian men, whereas the study of African American men was much smaller, only 10 times as small. And so I think really highlights that more work needs to be done. We need more studies that have representative populations and larger representation of minority populations to really understand the true rates of these mutations across populations and the benefit of these drugs. Moving on to the benefit of these drugs across men of different ancestral background or races, it's actually quite encouraging. This is a study of ProVEN, Sipuleucel T, that immune therapy, and a group looked at survival, how long men lived who received the ProVEN drug. And what this graph shows is that African American men in the dotted line actually lived longer who got this ProVEN treatment than white men who received it. And that's borne out over here. If you look at all men, African American men who received this lived 9.5 months longer. Remember, we talked about low PSA patients tend to benefit the most. And we saw that again here. Black men with low PSA actually really seem to benefit relative to white men, with the caveats this is retrospective. And I do think that this is a really encouraging signal that this is an approach that may be particularly effective in Black men. And there's actually some biology to support this, which I don't have time to go into today, but would be happy to discuss later or offline. The last two studies that I quickly wanted to mention focus on abiraterone and docetaxel, probably the two most commonly used treatments that most men with advanced prostate cancer get. Abiraterone, on the left, this is the results of a study called ABI-RACE that was conducted by Dan George and his group at Duke. And they prospectively, on a clinical trial, recruited 50 Black men and 50 white men to receive abiraterone, men with advanced prostate cancer, with the question of, is there a difference in response in benefit? And you can see pretty clearly the answer is no. This, despite what we know about disparities in prostate cancer, knowing that African American men have a higher risk of dying of prostate cancer than white men, the treatment seems to be just as effective. Likewise, sort of building on that, this is on the right, another study led by the group at Duke, where they compiled data from several clinical trials, 8,000 men, and again saw with docetaxel, men with Black men treated with docetaxel did just as well as white men. Really, those survival curves overlap each other, and so it really seems to suggest that our treatments, when given, are just as effective in Black men and white men. Really, I think an important point, because then really raises the question of understanding the factors that are driving this disparity. And so wrapping up, I think several take-home points. The first is that we have several, on the order of double digits now, effective therapies for men with prostate cancer, and new ones are coming. Some are on the precipice of being approved, others are on the horizon. And as I know Dr. Crawford's going to move on to speaking about next, it's an incredibly exciting time to be taking care of men and with prostate cancer, especially with the clinical trials that are enrolling and coming in the future. I think this is really important. Treatment of advanced prostate cancer requires a tailored approach. Every gentleman who comes into my office, I know is going to have a different disease course, have different medical comorbidities, different age, different disease characteristics, different genomics, different, on and on. And so I think really understanding that this requires a tailored approach for each individual patient. I touched on optimal sequencing of treatments and selection of patients, and I think that's going to be something that's a big area that's going to evolve over the coming years. And then, I think it's really notable that available data suggests that Black men do just as well with advanced prostate cancer and benefit just as much from treatments as white men do, and really, highlights the need to better understand the biology that differs between, or if there are biological differences, how we can exploit those to mitigate this disparity, and really sort of better understand the factors that do contribute to the clearer racial disparity in prostate cancer outcomes. And with that, I will wrap up. I believe there's going to be an opportunity for questions a little bit later on. But again, thank you for the opportunity to present, and I hope everyone found that interesting and educational. Thank you.
There we go. Thank you, Jacob. This is an excellent talk, and what I wanted to say, this is very complicated, and said, how would a person, a clinician, know which cocktail, or how do you personalize treatment for a patient? And said, what do they do?
Yeah, it's a great question, and I think really a big part of that is understanding who you're meeting, who you're caring for. Certainly, one thing I didn't discuss in this is treatments may have side effects. Understanding, how a patient's going to tolerate a given treatment. Maybe they'll tolerate one treatment better than another. Maybe there's factors. Some patients have symptoms, and I want a treatment that I know is going to have the highest chance of the patient responding and having improvement in their symptoms. Some patients with advanced prostate cancer don't have symptoms, and we know that we have a wider array of options. And so I think, Keith, it's really understanding the person who's in front of us, what their goals are, and what their disease characteristics are, and using this data that we have that it helps inform optimal patient selection to sort of decide in that moment. And this evolves over a patient's disease course. I showed that plot that shows there are several stages to this, and all we can do is make the best decision in that moment for that patient of what we think is going to be the most beneficial.
Thank you, Jacob. And what I want to do is also, if it's complicated, it's going to be complicated for the patient.
Absolutely. Yeah.
So
yeah. And so I think, the advanced prostate cancer space, as I think this talk probably communicated, is a little bit more complicated than the localized space when a lot of men are being diagnosed. And so, I think I wanted to say this at the outset, but just wanted to emphasize patient education is such a hugely important thing. And part of my goal, when oftentimes there's not a right answer about which treatment we should start in that moment, is to educate the person in front of me, try to educate them about what I know, and together with the patient come up with the treatment plan that makes the most sense for them.
Mm-hmm. And so what we're trying to do, and I have a couple of slides that I wanted to show, what we're trying to do is make sure we take on that position of educating the patient, because if it's going to be complicated for clinicians, how is it going to work for a patient who's going to be first diagnosed, and then you have to decide on what your treatment options are? So can I have those slides? Thank you. Now, next slide. When that patient receives that diagnosis and hears you have prostate cancer, this image is everything that the patient feels. They feel lost, confused, unsure, unclear, perplexed, disoriented, bewildered. What are they going to do? Next slide. And we recognize this. And that's why we created PHENpath.com. So when you get that diagnosis that you have prostate cancer and you don't know what to do, we can use a tool, PHENpath.com. Again, it can be on your phone, your tablet, your laptop, your desktop computers. It's not an app that you have to, you need to download. Next slide. So if you go to PHENpath.com and take a look at this portal. This portal, again, as we had mentioned before, we use very aggressive guidelines. We use the guidelines that are created by the National Comprehensive Cancer Network, the clinical treatment guidelines for their doctors. And this is in the palm of your hand. So when you're sitting with your doctor and they're talking about all these treatment options, you have a tool that you can go to. Next slide. Now, I always go back because, as I mentioned before, Tom has a message. And each tool, there's a message for each tool, and really reflects his journey along his 21 years survivorship. And he's saying here, he's a 21-year survivor, and he has experienced enormous challenges of identifying treatment pathways and the most appropriate treatment pathway for himself. Tom personally designed PHENpath to support the needs of all prostate cancer patients as they travel along their personal journeys. And this is why and how it was created. Next slide. So it's a very easy portal. And as you mentioned before, we try to group it according to areas of diagnosis. So the PHENpath can be divided into a segment: initial prostate cancer diagnosis, those people who were just recently diagnosed, versus the survivors who have recurrent disease, whether it's PSA recurrence after surgery, after cancer progression after radiation, advanced hormone sensitive cancer, and castration-resistant cancer. So in each one of these, you have the ability to go in and look at those trials that are those treatments that are specific for your diagnostic stage. And again, we also let people recognize that clinical trials are part of your treatment options. Next slide. And what I mentioned before, and what you've heard in the previous lecture, that's a complicated cocktail of mixtures and treatment options and wood therapy, immunotherapy, radiotherapy, surgery. What is it? What will a patient do? And in the past, clinicians would make the diagnosis and treat and give the treatment recommendations. But with PHENpath.com, we are able to, with the patient, work at having an informed shared decision-making process. That means the doctor gives a recommendation, the patient has the knowledge, and now there's more value and preferences or play a role in the decision-making process. And at the end of the day, hopefully the patient is more comfortable, more understanding of their treatment options than feeling left out and also possibly having regrets. So now what I want to do is I want to bring on a few gentlemen. Mr. Hall and Mr. Hall first. Dr. Hall, I should say. Hello.
Think I'm on now?
Yes, you're on.
Oh, Well, thank you so much. This program is just awesome. And I like to say being a prostate cancer warrior or champion, not too high on that survivor thing, but I did survive it. It just, if I may, it just clearly denotes how difficult this process is for a patient. So I think especially for a Black man who has a number of challenges with the healthcare system and then has to come to the conclusion that he has to learn as much as possible about this health situation and come up with the right decisions along with his doctor or provider. We just move just for a minute. The PHEN path, I just think is incredibly important. And unfortunately, when I had my diagnosis, it was not available. But having reviewed it and gone through it, I would tell you that the level of conversation that I would have had with my physicians would have been more detailed, and probably, folks who know me, probably would have been a little bit more challenged, because you're looking at guidelines from the 30 top cancer centers in America. And the reality is that a lot of practicing urologists don't know these intimately, may not know all the details. And as a patient, knowledge is power. You want to understand all the choices you have. You may come back around to the same thing that your doctor said, but you need to understand how he came to that conclusion or she came to that conclusion. And that's, I think, one of the great things that this tool, this education and empowerment tool does. I've known PHEN for a long time. Tom and I used to laugh because I'm like 40-year testicular cancer survivor, and he would tell me he was like a 12-year prostate cancer. Little did I know, after meeting him years later, I get prostate cancer too. And having known PHEN, my national navigator was out of PHEN, made my life so much easier. Now, my case is a little atypical because I got a great caregiver. My wife was the top doc in pharma and bio for years. Great access, got great coverage. Like I said, I had one of the best navigators, access to the best doctors, was at Dana and Mass General, and you just name them. I went to visit them, Hopkins. And so I had a lot of care. At the same time, all those things that were on that pole, all that unclear and all those feelings, they were right there. It did not change my situation as a patient. Okay, and having had already 2 cancers, it still was a new scenario. And I needed support to get through this. So one thing I would say is that the PHEN has manuals. It has someone like Keith who will listen to you until you have nothing else to say and then give it back to you in a way that you understand it. You have the tools. Having that available makes a whole lot of difference. And I encourage patients to come to PHEN early, get those tools, and then take them out with you on your phone probably or your iPad and talk to those physicians about it at each level, even the nurses, because everybody knows you and they know the kind of care that, well, you know the kind of care that you want to receive, and they should know the kind of care that's most possible for you to receive.
Thank you very much, Dr. Hall. I wanted to also segue over to Mr. Palmer. Now, Mr. Palmer is a caregiver. And so we'll have a perspective from the caregiver's perspective, from the warrior's perspective.
Greetings, Dr. Crawford and everyone. I'd like to take a moment, first of all, just to express my appreciation and gratitude for the opportunity to come forward today and to share my experiences as a caregiver. I'm serving as a caregiver to my brother. My brother is Robert Palmer, who lives in Norfolk, Virginia. I have served as an informal caregiver, and I say informal because I am mostly monitoring. I live in Chesterfield, Virginia, which is about 2 hours away. My brother was diagnosed with prostate cancer in 2018. He had a relapse in 2021. So what happened between 2018 and 2021? A lot of things. And I would say that I was a part of the initial diagnosis in 2018. I wish in 2018, I knew the things that I know in 2021. Because I wasn't, although I was part of the process, I was pretty much just living in the information provided by the doctor. It was a decision made to do a radiation treatment on him. I'm not sure if that was the best treatment, but that's what's decided, and we live with it. So in 21, he had a relapse. He had a very high PSA. I want to say it was some over 25. And based off of that, there was a decision to do cryotherapy. Cryotherapy was recommended from several doctors. However, after second thought, they waved it off and decided to go with a different treatment. The treatment is some type of injection. I'm not sure if you mentioned it, Dr. Burchuk, as part of your review, but the name of the injection is Lupron. The goal is to take the Lupron every 6 months. You had his first injection back in June, and the second one is scheduled for December. So I'm not certain what that's doing for him. He was scheduled to have a follow-up appointment last week on the 10th of September. However, due to a stroke and him being in the hospital, he was unable to do the follow-up. It's now scheduled for October. But I just wanted to share that as a caregiver, I'm so grateful to PHEN, to Dr. Crawford, to Adrian Backus, who introduced me to PHEN about 2 years ago, as well as members of my church. We have relied upon him and the information to equip us, prepare us to deal with prostate cancer. A number of members in our church were dealing with prostate cancer. So I used it as an opportunity to go onto the site and educate myself. I used it as a part of my preparation to speak to doctors regarding my brother. I would say it was very helpful. I also spoke to Dr. Crawford on some of the information that came out of those sessions with the doctor to provide more information. As a caregiver, there's some challenges, great challenges. Number one is education. As a caregiver, you got to understand what it is in terms of treatment options that are available out there. The PHEN site gave me an opportunity to do that. I also had a challenge regarding distance. Again, my brother lives in Norfolk. I lived in Chesterfield, Virginia, about 2 hours away. I know we live in a flat world because you can always use a phone and use these information sources. However, it makes a difference when you can actually talk to the doctor face to face, and I didn't have that. I think another challenge is just information. It has to be simple, it has to be simplified. If you're a first-time patient for prostate cancer, there's a lot you don't know. So you don't know what to ask. Even as a caregiver, you don't know what to ask. So I was very grateful in getting information from the site, but I wish I had more education years ago to help me out with the information. I think there has to be a way of simplifying information, not just for the patient again, but for the caregiver, where it makes sense, where you can make an informed decision. A lot of good information provided today. I don't understand it all, but it's good information.
Thank you, Mr. Palmer. I really appreciate it. And there was one point I wanted to highlight too. During that period, we spoke about this in session 1, the impact of COVID. And was your brother's screening delayed in 2020?
It was. He, because of COVID, obviously wasn't making the routine doctor's appointments. So during that time, obviously, I think his PSA was being elevated and there was no knowledge. So because he missed the appointments during the COVID, as well as some other reasons why he missed appointments, that all contributed to that PSA being elevated and being unmonitored for about a span of maybe 18 months to 2 years.
Okay, thank you. Thank you very much for sharing that with us. And thank you very much, Dr. Hall, for sharing your history and your background and your experience with us, and they're treasured. Next, what I wanted to do is in PHEN path, I had mentioned that there are treatment options, but also I had mentioned that clinical trials are possible treatment options. So what I want to do is I want to now move away from the treatment options, and I want to move to clinical trial strategies to increase patient accrual. Can I bring Dr. Heath online? Now, Dr. Heath is Associate Center Director of Translational Sciences at Karmanos Cancer Institute, and she also is a full professor at Wayne State University in the Oncology Center Institute. So, Dr. Heath.
Thank you so much. Oh gosh, Dr. Crawford, Mr. Farrington, and others, thank you so much for having me here. I hope you can see me and hear me well. Always appreciate time to talk about clinical studies just because it's so important. I'm not sure if you have my slides. I believe Jerry has them. If you wanted to share those, my goal with this session today is to maybe demystify the concept of trials. I think all of this wonderful work that Dr. Burchuk was just reviewing, are there options because clinical trials happen? But let me tell you where we're going to get stuck, folks. And that's in that concept of representation. All of this great work happens, and it happens routinely, monthly, yearly, every decade. But the constant struggle of not getting adequate representation continues to be present, and worse yet, not really going away anytime soon. So it's something that we as a community have to be more intentional. You're not going to know if a certain new treatment is the way to do things if you don't have the level of evidence that gives you confidence. So I practice, as Dr. Crawford mentioned, I practice in Detroit, Michigan, where the bulk of my practice is treating prostate cancer patients. And I have the luxury and the privilege and honestly the honor of meeting so many patients and also their family members and caregivers. And what I've learned in the 18 years that I've been here is that it takes an entire village to get it right. And what's happened in the last 5 years, as you can see all this great new treatment, is that these conversations are not a one-time deal. Even for patients I've had in my practice for 15 plus years, it is an ongoing conversation. It is a narrative, a series of them, because the science changes, you as a patient will change, your family will change, your community will change. And without that recognition that this is an ongoing process, you'll get frustrated and you'll get disappointed. And where PHEN has just been outstanding is recognizing any and all of those emotions and feelings and validating them because they are valid. When we talk about trials, people get so far into the weeds that all everybody thinks about is, wait a second, did she just mention a bunch of drugs that have a bunch of side effects? And kind of said that was a good thing. And I do this all the time. I'm in clinic 3 days a week. I do hundreds of trials a year. And why I try so hard to spend a lot of time, not just one visit or 2 visits, is that we know this stuff's complicated. I always say after meeting the first person, I think we just had a biology 101 lecture that you're going to have to keep hearing again and again. And that's a lot. It's a lot when you're not feeling well, or you're overwhelmed, or you're confused, and all of those feelings that Dr. Crawford showed on that slide, which is just phenomenal. But if you look on my next slide, which is sort of why would you want to consider a trial? I think the top one would appeal to all of our senses that, well, wait a second, if the evidence shows that you're actually going to provide me real data that shows that this new treatment is going to work better for me, then there is that level of confidence, not just in your team, but in just the world of science that, hey, this person's looking out for me because this is just studying a whole bunch of folks that look like me, and here's the answer. What happens a lot in medicine is that sounds good. That's what we aspire to. And then you see the numbers that Dr. Burchuk have shown, and we'll get a little deeper into that as well in this conversation. But the numbers show that there's no real representation of whatever is the group that you're having this discussion with. So if it's African Americans or Black men, that's maybe not represented. Asians, Middle Eastern, it could not just be race and ethnicity, right? It could also be where you live in the country. Are you in a rural place? Are you in an urban place? We just don't know. So the other part to this is, is it important to get the right representation of all of these when you're trying to also ensure that these findings or these recommendations that your doctor just gave you are generalizable to you? So the answer is, if it was in a trial, you hope that, yes, that it's there. It's also, as we mentioned before, an opportunity to really see if there's a difference, and a lot of, and again, we tend to focus a lot on race and ethnicity, but the geography, the economics, sometimes it's level of education, all of those contribute to having different response outcomes. So maybe it does matter, as we've seen before, where you live and how you respond. But we know that just for common everyday situations, that sometimes if you live in a city, it might be harder to get to somewhere. Or if you live in the rural communities that you don't have access to, let's say, a big cancer center that's maybe 4 hours away. This is what happens in real life. So we want to make sure if there is a trial that's available, that at least on the highest level, that's our goal. So the next slide will also kind of tell you, here's what's happened in the world of treatment. I know you've heard this before from Dr. Crawford and others, but here's a generalizable statement just based on a lot of data. Black men are less likely to undergo a prostatectomy. Black men who undergo a prostatectomy have a 20% higher mortality than white men. Black men with low Gleason score, like a 6 or a grade group 1, are twice as likely to die from prostate cancer compared to the non-Black men. These are very powerful statements. When I look at this and I look at my patient who is a Black man undergoing some sort of decision-making, I think these are powerful statements because it may just be, well, these were the decisions that were made 10 years ago, 15 years ago, but how does that relate to you? Those of you attending this webinar today, how does that relate to you? Well, you have the set of data. So let's say that, Black men are less likely to undergo prostatectomy, and that's just what the data shows. So if your doctor then recommends radiation therapy, is it because that's what he or she really thinks should happen? Are there the reasons why that is maybe based on your personal medical history or your wishes? Or is it just that's the way it is, and that's why the data shows that radiation happens more often? So all this does is empower all of you today, whether you're the patient or the caregiver or the community advocate, whoever you are, to know that it's really important to know where the data stands. This last bullet is really puzzling all of us in this field. The question is, wait a second, I have low-grade prostate cancer. Are you sure that's really right? Well, the data shows it is for the moment, but is it that just because we don't have big numbers of men in this position? Is it that we need to look at more information? But knowing this, it's important because it makes people think twice sometimes about using, let's say, active surveillance. Maybe you're in this group and you say, well, my doctors represent, you're thinking I'm okay. This is pretty low grade, nothing, I'm going to watch it. But if you know that, maybe that the data is showing that this is a higher risk group, you could push back and say, well, I understand that. But what I've learned from PHEN is maybe this would put me in a group that would make me a little bit more worried. Are there additional tests that could be done to see if I'm at higher risk of progressing and therefore need treatment? So these are the kinds of data that we're starting to get. Now, again, they're not trials. These are more just data sets that get reported, but still important. Next slide. So here's an example where we stand today in the US. The reality is that the Black enrollment on trials that are major, so I put phase 3 there for those of you who have attended different parts of this webinar or have perused the PHEN website would know that phase 3 is sort of where the FDA will look at this information to say, gee, did that cancer treatment work better than the existing and so on. So this is sort of that level of data that will help us. If you have anywhere from 2 to maybe 6% enrollment, it's hard to know whether the data really means that it's the right thing for you as a Black patient. Or maybe if you say, well, gosh, I'm really in a rural community, does this apply to me? Because they didn't really check that. Or, well, wait a second, maybe they did check race. I could tell you they didn't, but maybe they did. But did they check to see if I had terrible other medical issues that I would do as well? So as much representation as possible would help. And this applies to the new stuff. So that's just stuff we knew from 10, 20 years ago. But you're hearing all this information about DNA and all the stuff related to genomics, genetics, and genes, molecular testing, blueprinting. Just the words themselves are a bit overwhelming. But the idea is you want to know what's going on for you in your particular situation, sometimes also with how that affects other family members. But you're not going to know how this works if you don't get enough samples in the system. So you have this big data set that is all over the United States called the TCGA. Only 12% of those samples came from Black patients. So what does that tell us? Well, it tells us that we can only report the data based on what we have. If it was 40% or 30%, you might have more confidence that whatever gets reported could be really reflective for what's happening with you. And we're not left to just treatment and trials and all this molecular genomic stuff. How about imaging? You guys have heard about all the cool new PET scans. PSMA PET is all the rage. Well, in a PET scan study, not even using PSMA, here's a different tracer that you don't need to know the name of other than that's the stuff that gets squirted into you. 11% were Black men who were in the PET scan studies, 11%. So if you say, gee, is this going to work for me? The answer is, well, we're sort of taking, maybe here's the data and I'm going to maybe kind of apply it. Is it? I don't know. So there's a lot of hemming and hawing for all of these 3 buckets, but that's where all of you as part of this webinar and this growing prostate cancer community full of advocates and educational experts like those at PHEN really can make a difference. Next slide. So let's drill down now to a summary statement in things of what Dr. Burchuk was saying. If you get on a clinical trial, the general answer is you're going to do just as well as the white patient on that same trial. There was a lot of worry, and I've been doing this a while as well, that, gee, if I'm a guinea pig on a clinical trial, am I going to get the good stuff, or are things that are harmful going to happen to me? And I can say to you that with all of the proper regulations, and trust me, way too many paperwork trails and so on, our number one job is to keep you safe and to also make sure that we do things ethically. So if we can get you on a trial, and this could be in early disease, like, oh gosh, I just got diagnosed, to, oh no, I have metastatic disease and I need different treatment. Once you get on one of these studies, there's really no difference in how long you live or any of the other parameters. And that's true for industry-sponsored trials. That's true for what we call cooperative group, but they're all basically trials all around the United States. And you know, in addition to the resources of PHEN, you have clinicaltrials.gov, which is also another way to look at studies. But like everything else, it's just navigating the system, and nobody makes it easy. Next slide, please. So here's a little bit of a closer look on that Provenge or Sipuleucel T. What I think the take-home message here is that it's not just that they're the same, but that perhaps in certain instances, it's better. So that's not a concept that we're used to. I'll tell you, the only other trial I know in medicine that potentially might favor the Black or African-American individual is a hypertension drug that's actually got approval for just that subset of folks. But in the new world of cancer, sometimes we know, based on, let's say, how your genes are behaving, that different subsets throughout the globe behave differently. So for example, in lung cancer, sometimes patients of Asian descent, whether you're Japanese or Chinese, might have a gene that might work better with a new drug with lung cancer than the white patient population. So all of a sudden, we're getting to the point where we can really look deep and say, is there something else out there that might even make me respond better? So here's an immunotherapy drug that's been approved for many, many years. It took a really long time for ourselves and Dr. Sartor, as an author on this paper. I was honestly really happy to see that, wow, there's something there. And if you get it in right, like as we were talking about all of these guidelines, that it's something that perhaps you as a patient should ask for. So don't wait there passively to say, gee, my doctor didn't bring it up. Part of this whole issue is you being empowered, whether it's the patient or, again, your advocate or your caregiver, to say, well, hang on a second. I was cruising around this PHEN website and it says, what about this treatment? Because even though doctors know what's out there, sometimes it's not what they do. Not what they do because they don't want to, but it's not sort of their regular way of how to approach a problem. So I've had patients ask, well, gee, what about this or what about that? And you know what? I love that. I love that because that means somebody's been looking, somebody's been asking questions, and that's what you need to do. Not just once, not just twice, but multiple times. In the next slide, you'll even see, just like what was mentioned before, here's chemotherapy. I mean, the dreaded chemotherapy that a lot of us might say, oh gosh, we're going to do everything possible not to do chemo. As a medical oncologist, I don't fight too hard about it. I know all of these drugs have side effects. I know all of them will affect you and your family and your caregiver. I think it's just hoping for the right drug at the right time. But chemo, and you could just see all of these trials, look at them all. They're all similarly, done where a bunch of folks with spread prostate cancer got this chemo called docetaxel. And yes, 6% only were Black, but still better than 1%, of which the previous studies are really at 1 or 0%. There's no difference. So if you get chemo, you can say with some certainty, I'm going to get the same result and a good result. So this is solid data that really needs to be known because it's important for those who need chemotherapy, whose care depends on chemotherapy. So it's a discussion that you're now empowered to have with your doctor. The next slide also goes into one of the new drugs called radium or Xofigo. a lot of my patients know about this medication, not because you had to do a 5th grade project on Marie Curie, but just a lot of movies and a lot of chatter now in social media about this. But even this drug, this is not a chemo, this is not a pill, this is what we call sort of liquid radiation, but it's a radiation given to men who only have cancer in their bones after they've been on Lupron and a lot of hormone therapy. What's it show? Well, it's a retrospective. You know what that means? They took time to really look at how did people do if you got this. Sometimes you can't run all these big fancy trials and get thousands of guys on here. Sometimes you just got to look at your own data set. Well, it's pretty consistent at the VA and how care is delivered. So fortunately, within the VA system, you can really get a lot of uniformity. But the right answer to this is there's really no difference. In fact, if anything, Black men did better and had better overall survival, i.e. you live longer in those who had received radium. This is encouraging data. It's important to show that it's there. It's 318 patients. Is it 3,000 patients? No. But is it data that you can have in your back pocket? You bet. The next slide is another medication that we give all the time. And I'm sure many of you on this webinar already know this. It's abiraterone. It's been around for several years. This is the study that Dr. Burchuk was mentioning that Dr. George did. Well, at the Kermanos site, we were the second highest accruer of patients who were Black or African American. And the best part of this is recognizing not that there's a difference, but committing to this study. Let me tell you what happens in the real world. It takes a longer time to complete these studies. We can accrue white patients very quickly. They get in there, they sign up, we get the treatment. It took us many, many more months with a lot of, we're going to shut this down, we're going to shut this down. And all of us, the Duke people, us at Kermanos and several other sites said, we're going to stick to it. We need to know this answer. So what does that mean? That means that if you're a pharma company, you might have to pay more to keep the study open. So that is a reality of us taking a long time. But if many of us in our industry commit to doing these kinds of trials, we, number one, can get it done. Number two, we can show some really important information. This important information is, yes, we know abiraterone is approved, but how's it going to work if you're a Black patient? And the answer is exactly the same. So in this instance, we feel happy that there's at least some data to show that there's importance in. Also, you look at the PSA decline. Black men did better on getting their PSA down. So going on to the next medication, and I'm just giving you a slew to say, this is not a one and done. It's not 2 drugs and we're moving on. This is not just chemo, but pills and everything else. So here's another one, enzalutamide. Many of you on this call probably have heard about it or are on it. In this instance, what's important is to also show, hey, this was a study that we ran, same issue. It took us a long time to finish because it's a commitment to get the number of patients. But let me point out one thing. So if you look at people getting enzalutamide in patients who have spread disease and just got started on their shots and they're on these pills, if you look at just people getting enzalutamide, which was half the group, they did about the same. Your PSA response was about the same, no problem. But if you looked at the other group on this arm, which was the people who got bicalutamide, which has also been around as a first generation anti-androgen for a long time, you can actually see that the Black patients had a lower response on their PSA. So all of a sudden now it's just not the same or better. There's a little bit of worry that you're doing worse. So in this case, that worried us. And that should get you guys on this to say, well, gosh, if we didn't do these kinds of trials, we would never see this. And why is this important? Next slide. This is important because I can just tell you from a real world perspective that there's still a fair share of bicalutamide and those first generation anti-androgens being prescribed today. So that means that the word isn't out. That means it's up to you guys and you as family members, as patients, to be aware of this. Now at our shop, we feel so strongly about figuring out how to improve these numbers. And we do a pretty darn good job already for our prostate trials. I can tell you that in our prostate cancer trials, we have 40% enrollment. And I'm such a high overachiever that that's not enough for me. I wish it was 50%. I wish it was 60%. So every year we try to do better. And part of the effort is each institution's got to figure out what works for them. You know, where PHEN is just phenomenal is that, especially now, where we're now all virtual, these resources live online. But we all have our constraints throughout the US in terms of what the challenges are. And what happens in Detroit is different than in Boston, then it's different in Virginia. So you got to figure out the lay of the land. In our hands, what we decided was to recognize that although we were pretty good, like we knew how to do this, we encouraged our partners at Johns Hopkins to kind of hang out with us on the study. And we said, you know, I think we could actually even do better, not just for patients and giving them a prompt list of like, here, take this question list and go ask your doctors to help you. But we were trying to educate the doctors to make sure that one, we communicated, and two, we didn't have implicit bias to go, well, jeepers, the patient in front of me, you know, he's 81 years old. He's not going to have time for this, or he's going to have transportation issues. So like we put our own biases in here, and that's what we found out, that what we really should be doing is not just targeting patients, which is you guys and family members, but also targeting the health system and making sure that doctors really recognize this challenge. So this is a grant that's near completion, and we're going to hopefully do more of something like this, but we've recognized this to be a really important approach. Next slide. So as we mentioned here, and I know that Dr. Crawford probably mentioned, is that most men that we found out anyways in this study are very willing to talk to you know, their doctors to talk about clinical trials, but there's still a slightly higher level of suspicion and warranted that the trust factor has to be there. So a lot of the times the doctors talk over the heads of just not the patient, the caregiver, but like the advocates sometimes, if we have advocates. So you don't get down to brass tacks. What are you really trying to treat me with? And why are you picking it? And why are the other options really not what I should be doing? I could tell you that the other finding we had was that, you know, of course, once we figured out that, yes, we have the patients, you know, interested and ready, the other problem was we didn't make the offer. So once we figured out that we put our own bias into that, we don't make the offer, which means you never hear about the study, because I kind of made that judgment in my head that you didn't need to hear it. And that's the kind of part on a prompt list. If you had that, you say, gosh, maybe what I should do is ask these 10 questions to my doctor and see what he or she says. So that's a tool that, of course, is something to have in your bag of tricks to make your visit go much better and more streamlined. Next slide. So when I went back to say, gosh, you know, all these folks getting bicalutamide, well, what does this mean? So let me just tell you that even us getting you and your loved ones on a clinical study, it doesn't end there, because the reality also is you have to be prescribed the medication. So recently this year, there were these data sets that got reported, which was, well, that's great. You know, boy, oh boy, Dr. Heath, Dr. Burchuk, Dr. Crawford gave great data to say, this is the trial, this is what we should do. But let's see if it's really happening. So this was a real world analysis. Okay, let's see what the doctors are really doing. And let me tell you that what's really happening is that not all of the patients are getting the treatment that they should be getting. And not because of any one particular reason, because I don't know if anybody knows that, but less than a half of the folks who should be getting extra medication in addition to their shots, for example, are not getting it. And in a few of the data sets, that is even more so in Black men versus white. So that disparity continues. So one, I hope everybody who's listening today will at least consider a trial, but better yet, ask to see if there's a trial that is available for you. So we used to have buttons in our clinic that said, ask me about a trial. And inevitably they look at this and go, did you want me to ask you about a trial? And the answer is yes, I would love to talk to you about a trial. Sometimes the answer is, oh gosh, there's no trial for you. Or, hey, we have several, and we're going to talk about this and spend some real quality time so that you know what's happening. Next slide. So what's really important about this is all hands on deck. And where PHEN is just phenomenal is the resources they bring you is so incredibly comprehensive that I encourage all of you to leverage not just one resource, but multiple resources over multiple time points. Your journey will change. So whatever conversation you had 6 months ago with your physician may be different than what's happening now. And it may be very different than what happened 5 years ago. Any part of this journey, trials are important, but you probably, just again, by our own data, might not get offered one. So it's up to you to ask, is there a trial for me? And it could be anything. It could be a treatment trial. It could be a registry trial. It could be a quality of life trial. It could be a biomarker trial. It could be an imaging trial. If you don't know the answer, it's a trial. So the more you contribute, the better our guidelines will be. And the fact that there are guidelines, there's also that knowledge that you will have to know that, wait a minute, I thought the standard of care was to add something here. So how come I'm not being offered? So that you've empowered yourself. And that these resources will tell you, as the field is changing so quickly, we're all barely keeping up, that you will have an evolving set of resources that you can always come back to learn more. So I believe this is my last slide, Dr. Crawford, and I'd be happy to take questions or answer anybody. So thank you so much for this opportunity.
Well, thank you, Dr. Heath. It was an excellent presentation. I think that what I want to reiterate is your last slide: encourage, implement, and utilize. Now, I wanted to take a quick couple of minutes, and I wanted to bring in Dr. Davis. He has a luxury of seeing this in two different vantage points. He's a physician, but he's also a patient. Dr. Davis?
Good afternoon. Let me just say initially that this is an honor for me and a very good position for me to be in, since I am from both sides of the sword, so to speak. I've been a physician for the past 50 years of my life, and I've also been a prostate cancer survivor for the past 7 years of my life. And it's been a very interesting path to follow. Let me just say that PHEN is such an important aspect of knowledge and a point where men can gather together in unity. That's a little phrase that I want to put out there, because it's important for us to gain knowledge and understanding about ourselves. As men, we tend not to do that. As men, we tend to get involved with athletics and partying and have a good time, but we need to be responsible for our health. We need to be responsible for ourselves. And one of the ways, and an important way to do that, is through knowledge. One of the things that I think is important, especially in dealing with our health, is that the groups that men tend to be involved in, and I'm going to describe that very carefully. The fraternal groups, number one, that we tend to become involved with. The social groups that we tend to become involved with. The educational groups that we tend to become involved with. Are we including our health as an important aspect of those groups? And unfortunately, the answer is no in a lot of cases. But through PHEN, through an organization such as this, we can become involved and we can gain knowledge in these areas and share them with our friends, share them with our family members. And especially in my case, it's very important because I made sure that my son is very much aware of my path through this cancer trail, and that he's concerned about his health, and he knows that his family members and their friends are going to be concerned about their health. Unfortunately, as men, sometimes we're supposed to, or it's a thought that we understand everything. We know what's going on, so to speak. But we all know, guys, that there are a lot of times that we don't know the answer and that we aren't sure. And unfortunately, rather than seeking the knowledge and seeking the answers that we need to, we're afraid to admit and acknowledge and to inquire and to reach out. And certainly I feel that PHEN is such a group that provides that for us. And so really there's no excuse for us not to have the knowledge that we need. There's no excuse for us not to participate and to become active in an organization such as this, so we can learn about ourselves. And so we can pass this information on to our friends, pass this information on to our family members, so they can get involved and so they can see the importance of understanding as much about themselves and about their health as they can. And I think that each of us should take this on as a responsibility. As a man, we need to take on these responsibilities. And I think PHEN provides us such a good example, a pathway to become involved knowledgeably, to really understand, to know those things we know and to know those questions that we don't know and where we can seek those answers. I think PHEN provides an excellent outlet for us to do that and for involvement. So let me just say that I'm so glad to be a part of this organization and to utilize, as I said, sometimes when in some of my social groups, when the guys see me come and say, "Oh, here comes Jack," we know what he's going to say. When's the last time you had your exam? Even sometimes I'll even ask the guy, "What was your last PSA? What was your last blood pressure? What medications are you taking? Why are you taking these meds?" When I stimulate the guys to make their doctor visits important, and I tell them, write down the questions that you plan to ask your physician or your healthcare provider. And believe me, we all know that when you walk into the healthcare provider's office and you sit down and you pull out your sheet of questions or your sheet of information that you want explained to you, your healthcare provider is going to pay attention to you. He's going to spend time with you and make sure that you understand exactly what's going on. And if you have the type of physician that you should have, if he can't provide the answer for you, he will guide you in the direction and lead you down the pathway so that you can find those answers. So I just want to say thank you so much for Tom Farrington and for the group, for Dr. Crawford. I'll end my discussion at this point.
Well, thank you, Dr. Davis. It was great to hear your words and what your thoughts are, especially through a dual lens. And what we recognize, what's so important is that we talk about the patient, we talk about the caregiver, we talk about communication. So our next speaker will talk about a concordance. Is the patient conveying the same information that the caregivers is conveying? And so what he's going to talk about is a variance in symptoms assessments between patients and caregivers. And this is Dr. Jay Javieri. He's an MD and he is a medical affairs doc in oncology at Bayer Pharmaceuticals. Jay?
Thank you so much to Dr. Crawford and the entire PHEN organization for organizing this presentation today, as well as putting together such a fantastic committee where we're able to discuss these important issues. As Dr. Crawford mentioned, my name is Jay Javieri, and I'm the Director of Medical Affairs Urology at Bayer Pharmaceuticals, Medical Affairs Oncology. Give me one moment while I tee up my slides here. Hang on just for 1 second. Please pardon the interruption. So a brief background about the study that we have is that it was already published for the Western section of the American Urology Association as an abstract, which means that according to what Dr. Crawford was talking about, sometimes patients don't necessarily report or observe the same things as the caregivers do because of their different perspectives on life and on how the patient is doing and all of these other factors. So we decided to partner with an organization who was looking at that in a little bit greater detail. So the organization was the Genesis Healthcare System in San Diego. And I just want to make sure, can you guys see my slides right now? Okay, here we go. Yeah, thank you. Great. There are my slides. Excellent. So yeah, as we were mentioning, we're going to be talking about the variance in symptom assessment between the patient and the caregiver, in that sometimes the caregiver reports things the patient doesn't, sometimes the patient reports things the caregiver doesn't, and it's important to get on the same page as a way to address and really begin those discussions with your physician. Next slide, please. So as some disclaimers, I mentioned that I was the employee of Bayer Pharmaceuticals. These are for reactive medical scientific engagement. Being that we were invited to give the lecture here, we were very happy to do that. And we have no liability for miscommunication of these messages. And we can continue on to the next slide, please. Thank you. Right, so as I mentioned, this has already been accepted as an abstract for the Western section of the American Urological Association. The title of the entire abstract is The Variance in Symptom Assessment Between Patient and Caregiver, a Prospective Study of Patients with Metastatic Prostate Cancer. This will be a podium presentation and presented at the end of October or maybe the first week of November, depending on exactly where they place the authorship. Sadie Swift was the first author, and as I mentioned, Dr. Franklin Galis is one of the people in San Diego who are organizing these initiatives towards evaluating both the patient as well as the caregiver in order to find out some information about both. Next slide, please. So the objectives of the abstract were to, as we mentioned, patient-reported outcomes are very important to see what the patient feels, but really what they describe, because sometimes what they feel may not be what they describe. So patients with metastatic cancer are particularly vulnerable, and they really benefit from having a lot of different people involved in their care, as we talked about shared clinical decision-making, as well as a multidisciplinary approach throughout the whole lecture today. So timely and accurate information becomes really important when reporting symptoms or discussing what the treatment pathway may be, because what the patient says actually influences what the clinician is going to do, because as Dr. Heath mentioned, there are a lot of different things that everybody evaluates during one clinical visit. So these are the important things to discuss with your physician. Discordance is basically a measure of similarity or a way to compare two things, whether how same they are. And we looked at that between the patient and the caregiver. The authorship looked at that. So we're going to report those results and describe them to you today. Next slide, please. So looking at men over the age of 18 with metastatic prostate cancer on androgen deprivation therapy, or those shots that people get to reduce the testosterone levels, patients and caregivers were asked to fill out 3 quality of life measures. These are all different surveys that evaluate pain. The brief pain inventory looks at pain and different aspects of pain. The functional assessment of cancer therapy also looks at different domains of your life, as does the EuroQol5, EQ5D quality of life questionnaire, basically asking questions about how you function, emotional well-being, happiness, depression, things of this nature. PROs versus CROs. CROs are caregiver reported outcomes and PROs are patient reported given outcomes. And we did statistical testing to actually figure out if the same thing was coming up repeatedly. And using the FACT-P and BPI, this is a little bit of statistics knowledge, chi-squares were used to compare those values, and t-tests were used for the ED5D score. And significance was considered at a level significance value or probability value of less than 0.1. Next slide. Sorry, 0.01. So there were 101 patient and caregiver dyads, which means that there was one patient to one caregiver appropriately matched. Those were the people enrolled in the study. Out of the 101 caregivers, 77 were spouses or significant others. 77% were spouses or significant others, meaning people who were involved in their lives. You guys are all familiar with the dynamic relationships patients have with their caregivers. 16% were relatives, as is Mr. Harris's, Rodney Palmer's example. 2% were non-related friends or social workers, and 5% did not really disclose their relationship. Now, I understand that this is not the full gamut of data that we are going to present regarding this, but a significant difference between the caregiver and the patient was reported at the statistically significant pre-specified value between the caregivers and patients in perceptions of the patient's emotional well-being, their mobility, self-care ability, pain and discomfort, and anxiety or depression. So really the take-home message here, or the important thing to think about, is what are we talking about when we talk about patients, caregivers, and the physician relationship? When you're there, are you asking the appropriate questions? Do you know which questions to ask? Is it important that your caregiver joins you? Because who can activate the appropriate discussions to make sure that the doctor is getting the full picture to understand your clinical situation? I thank you very much for your time and attention, and I'll turn it back over to Dr. Crawford. Thank you very much.
Thank you, Jay. And then that was an excellent synopsis of the research. It's important research also, because there's always a disconnect between the caregiver and the patient. Now you're bringing this information together, and more clinicians recognize this, the better that they can treat the patient and participate in the shared decision-making process for both patient and caregiver. Now, what I wanted to do is thank you again, and I wanted to transition over, and what you've heard from Dr. Burchak, concepts like radioligands, this next generation or personalized care or tailored care of a patient. So we wanted Ms. Dawisic, she's from Blue Earth Diagnostics, to kind of shed some light on precision radiopharmaceuticals for patients with cancer.
Great. Thank you, Dr. Crawford. I have to say this has been just a significant program. I can't thank you enough for inviting Blue Earth to be a part of this. And really just to complement the panel, the breadth of the panel here, the information shared really has been remarkable. Jerry, if you don't mind sharing my slides, that would be great. So Blue Earth, let me give you a little bit of background on who we are and the topic that we're going to discuss today. My name's Anne-Marie Dawidzik, and I lead patient access and advocacy for a company called Blue Earth Diagnostics. We're invested in developing new precision diagnostics to help physicians identify the state of a disease and the extent of a disease. And our particular area of interest is in precision diagnostic radiopharmaceuticals. And I'm going to spend some time today just explaining some innovative developments in the imaging area. Dr. Burchak actually mentioned one, as did Dr. Heath. So I'll take some time today just to give you a perspective and some of the questions you should ask from a patient and a caregiver perspective. Next slide, Jerry. Thank you. So our company is Blue Earth. We started in 2014, really based on working with one molecule. We developed this molecule. We became really, based on our growth, a global company. And because of our growth, we were acquired by another imaging company called Bracco in 2019. Next slide, please. Bracco is well known in the imaging community. They have a breadth of products in the conventional imaging area. And the drugs that they develop are used in conventional imaging, such as CT, MRI scans, ultrasound, and even in an innovative area of colonoscopy. We're part of a company that is present in 100 different countries, and we have about 3,500 employees. All of our companies are focused on developing solutions to help physicians identify, diagnose, and develop care treatment pathways for patients with significant disease. Next slide, please. So I'm going to use our product as an example of the developments that are going on today in imaging. Both Dr. Burchuk and Dr. Heath have talked a lot about the areas of treatment that are, the innovations are endless and really providing so many opportunities for improved treatments and outcomes. The area that we focus on is imaging. And to give you an example, our product, fluciclovine, which is known from a commercial perspective as Agjumin, is used in the imaging space, in the advanced imaging space of molecular imaging. It's based on an amino acid that was discovered and studied at Emory University in Atlanta and licensed by General Electric. Next slide, please. Blue Earth is the company that actually commercializes this product. So using Agjumin as an example, this very specific molecule is indicated in men who have prostate cancer, a recurrence of prostate cancer based on an elevated PSA following prior treatment. So this drug is used along with an imaging modality called positron emission tomography or a PET scan. This is the advanced imaging modality. All of these imaging, advanced imaging modalities do need drugs to produce an image for an oncologist, a nuclear medicine specialist, or a urologist to view. And as a result of this image, the physician identifies the absence, presence, and extent of the disease. Now, using Agjumin as an example, I think Dr. Hall mentioned something very important, that he had access to great treatments through the coverage and access that he has. All of these innovative treatments are going to, your access is going to depend on your insurance coverage. Agjumin, we've done a lot of work to make sure that this product is available through most insurance companies and also through Medicare. This drug is used as an imaging agent. It's injected into a patient. The patient is then put into a scanner, a PET scanner, and an image is projected for your clinician to read. Next slide, please. Now, excuse me, just to mention that this is a drug. As Dr. Heath mentioned, each drug has a safety profile. And we need to make you aware that one exists for Agjumin. This is information here. Also, information exists on the agjumin.com website. Next slide, please. Excuse me. Losing my voice. Just to give you some background on what molecular imaging is. So you'll notice that there's a machine here, piece of equipment. This equipment is actually located in a nuclear pharmacy. The interesting component of drugs like Agjumin, diagnostic radiopharmaceuticals, they actually have a bit of radioactivity attached to them. They're very specific molecules. They target very specific tissue or organs. In our instance, Agjumin is targeted to prostate. One indication is for prostate tissue. So once your physician identifies that perhaps they need more diagnostic information, they'll schedule the PET scan. The imaging facility will work with a local nuclear pharmacy to identify when to produce or compound this drug. It's usually delivered on the same day that you have the treatment, same day that you have the image taken. About 3 to 4 minutes before you have the image, our drug, if it is the drug of choice, will be injected. You'll be placed into the scanner. The scanner takes about 20 to 30 minutes to complete. And then information will be provided on a computer screen as depicted in the image here on the screen as an example. And the nuclear medicine physician, your radiation oncologist, your medical oncologist, your urologist will collaborate on next steps. What's the best treatment option? What's the best treatment available to you for your particular stage of the disease, and also the extent of the disease. Now, there's a lot of development going on in this field right now. Agjumin is one example of a drug that's used in the diagnostic imaging space for prostate cancer, in the advanced imaging space with prostate cancer. There are others on the market. There'll be differences between the drugs. It's best that you discuss what's available to you with your physician, depending on their location, on which institution, which hospital or imaging center they have access to, will identify and contribute to your availability of this modality. Next slide, please. I'd like to talk a little bit about some of the developments in the imaging space. Now, Dr. Heath did mention that representation in imaging trials is not where we want it to be in terms of representation by all types of patients. We are doing, we're conscious of that at Blue Earth. We're doing a better job in terms of working with sites to recruit a better representation of patients. That is something that we're aware of, and moving forward, it's in our consciousness to make sure that that is something that we improve. Agjumin is only the beginning of the imaging portfolio for us. We do have other products that are under development that would be considered next generation. And there are all kinds of products in the imaging space available today that are under development and in clinical trials. The best resource to identify where those trials are either the manufacturer's website or the clinicaltrials.gov website. In most cases, clinicians may be aware of who is conducting these studies if they are underway, and your eligibility to enroll in those studies. The next agent that we're working on in the prostate space is rhPSMA. It is in phase 3 studies, which means that we'll be approaching the FDA about an approval in the near future. One of the benefits of some of these diagnostic radiopharmaceuticals is to identify also not only the extent of your disease, but which patients would be most appropriate for treatments. Dr. Burchak mentioned that one of the treatments that likely will be approved in the near future is lutetium. Part of the studies that are going on with that drug are identifying which patients would most be appropriate for those trials, and that includes using diagnostic imaging with these types of imaging agents to identify the most appropriate patients. Next slide, please. So just to mention, in that the agent can both be used in a diagnostic format and also a therapeutic format. rhPSMA is one of those examples. So there are a lot of innovations going on in our field. I would recommend that you ask questions, as many of the panelists mentioned today, asking questions about what is available to you and what resources are available to you to gain access to those. A lot of good information exists on both hospital and imaging site websites, as well as manufacturing websites, to better inform patients about what questions to ask your provider, but also what questions to ask your payer in terms of which products are available. This is only the beginning. Next slide, please. This is only the beginning of really the development of imaging agents. It's changing in a remarkable fashion in terms of the number of products and number of imaging agents available. And it's also changing in terms of the patient populations, whether it be initial staging or patients who've had prostate cancer and are having a recurrence. Depending on the agent, the diagnostic imaging agent, and your stage of diagnosis, different agents may be used to help your doctors better identify improved treatment options. A lot of data exists about changing management plans and treatment options after having more diagnostic information available, as provided with PET imaging and Agilent, for example. In about 60% of the patients who are enrolled in our studies, their treatment plans changed, whether that be more in a curative or palliative manner. So these are invaluable resources to patients, but you have to be informed about them and ask questions of your physicians as to what's appropriate for you at the time and what you have availability for. So I appreciate the time here. I know we're coming up on time, Dr. Crawford, so thank you for allowing us to share some information.
Thank you, Anne-Marie, for that special presentation, because I know a lot of people were very interested in what's this radioligand, what do they do? And that was very important for you, for them. And thank you again. And thank Jay also for your special presentation. Now, we have one other presentation we like to make, and it's something internal that we like to convey to everyone out there in the area who's interested in genetics and genetic testing. This is a surprise, but we would like to announce it to our audience, what we plan to do moving forward when it comes to genetic testing. So we'll just have to restart it just a little bit. Bear with us. We're adjusting the sound. Hello, everyone. I'm Dr. Keith Crawford. I'm the Director of Clinical Trials and Education at Prostate Health Education Network. I'm joined today by Dr. Todd Cohen. Dr. Cohen is the Vice President of Medical Affairs and the Medical Director of Urology of Myriad Genetics. Dr. Cohen, thank you for joining us.
Oh, thanks for having me, Dr. Crawford, and hello, everyone that's watching today.
First, I want to give everyone, all of our viewers, a little bit of a background refresher. We know that early detection offers the earliest chances for cancer-free survival. Now, the CDC has already reported greater than a 98% life expectancy if prostate cancer is detected early and it's localized. Genetic testing can play a significant role in early detection screening, allowing for one to understand the type of cancer and the possible treatments of that cancer. Genetic testing allows prostate cancer patients the ability to better understand the relationship between genes, cancer, and treatment. In doing so, patients feel like they can better understand the diagnosis and their treatment, and then allowing the patient to feel more in control about their care. Dr. Cohen, can you tell us a little bit about genetic testing survey that you conducted, that was conducted by Myriad last year?
Of course. Well, and thank you. Those words were very timely. And last year, we sent out a survey to gauge people's interest and their knowledge base on genetic testing when it pertains to prostate cancer. I think there's a big misconception that genetic testing is really for the breast cancer patient, but we're finding that it's probably more prevalent in prostate cancer actually than it is even in breast cancer, which is something that we're learning more and more about these days. So we sent this survey out to find out what people's knowledge is and their interest it would be in getting tested. And we found that about 88%, so almost 90% of men would seek genetic testing, to qualify for potentially additional prostate cancer treatments, like you stated, especially if they were available in their area, and of course if they could afford it, because there is always some cost considerations. About 87% or almost 88% of men would seek genetic testing because it not only can tell them about their own cancer, but it can also help identify mutations in genes that may be running through the family, and it could help their family members either identify their cancers even earlier, or family members that may be at risk for developing cancers. And finally, 89%, almost 90% of men would order a genetic test if it was available, just to have it and know the information if it pertained to them especially. So I think it was very interesting to see the high levels of interest among men when asked about genetic testing.
Dr. Cohen, those are some amazing numbers. So what you're trying to tell me is between 88 to 90% of the men responded favorably.
Yes, that's true. It's really, and I agree with you. I think there are amazing numbers, is that when given the opportunity, men would go out and get tested for themselves, like you said, for potential treatments, but also for their families. And I think that's a very important thing to consider too when you get tested for genetic abnormalities.
And Dr. Cohen, did the men in the survey disclose barriers to genetic testing? And if they did, could you kind of discuss some of these findings?
Yeah, well, there's always barriers, and I think it's a relatively new field when we're talking about it in the context of prostate cancer. And I think right now there's several issues why men may not want to get tested, or the barriers to potentially, even if they want to get tested. And the first one is probably trust. It's the question of, if we have this information, what are we going to do with it? And is it going to interfere with their privacy, or is it going to be used for other purposes than to help them with their disease process or help their family? And there is protections with that. The government has set up protections for this long ago, to ensure that there is protection against people using this against them for certain things. Cost is always a consideration as well. People worry about, how much is this going to cost me? Is it very expensive? In the vast majority of cases, if men qualify for testing, there's little or no out-of-pocket expense at all. And when there is an expense, it's usually very small. Now, occasionally you're going to have those few people that's not going to be the case, but that's a rare instance that we found. Some of the bigger obstacles, even if men want to get tested, is that their doctor doesn't offer it, and they either don't know how to get to it, or they don't feel they're not as knowledgeable in it, so they don't want to give the test because they don't know how to deal with the answers. And so the doctors just don't offer it to their patients. Other times, patients feel like the whole process may be too difficult, either for themselves or, how do they get to the doctor? Or is it a transportation issue? Is it how do they get tested? We're doing everything we can to make that easier and easier, even to bring the testing to people's homes. And finally, there are men that just don't qualify, that they can go out and they want to be tested, but they don't meet the certain qualifications that allow them to be tested. So I think all of these work together as barriers, but we're breaking through a lot of these. And I think knowledge is a wonderful thing to get people in so we can get rid of a lot of these barriers.
Well, Dr. Cohen, I mean, it's time to address some of these issues. And this is why this is such an exciting discussion, because in October, PHEN, in partnership with Myriad Genetics, will be launching the 30 Genetic Answers in 30 Days campaign. Is there anything particular that you would like to discuss about the 30 and 30 campaign to our audience today?
Yeah. Well, yeah, you're right. We really want to get the word out, and we want to get the word out in several different ways to make men aware that this testing is available. So we started this campaign to tell men this is just not for breast cancer anymore. This really pertains to them. And like I said earlier, it can actually be more common in men with prostate cancer than women with breast cancer. And we're trying, or the goal of this initiative is to try to test at least 30 men over the next 30-day period. And during this time, though, we're really hoping to have 3,000 men. It would be wonderful, but our goal is 30. If we can get more than 30, 300, 3,000, 3 million men, that would be even better. So we can get men out there and understanding, the genetics and, behind their prostate cancer. So it's really an exciting collaboration between PHEN and Myriad to get the word out.
And that's why I said that this is extremely exciting. We knock over cost, trust, and access to genetic testing barriers. So one other thing I wanted to ask you, can you tell our audience, how can they get the kits?
Well, it's actually very simple. You can get a genetic test sent directly to your home. And on the screen, you'll see the website where you can link to and order the test kit. Once you get the test, though, you'll have to bring it to the doctor, to your physician, or to a physician that will provide the test results to you in order to have the test be done. This is purely because we want to make sure that the physicians and the patients are in this together, and they can get the answers once they have the results of the test done.
So let me be clear. I mean, our viewers can have the kit sent directly to their home at no charge?
Correct. All they do is go to the website, put in their address, and the next thing they know, in the mail, they will receive the test kit.
Well, yeah. Dr. Cohen, thank you. Thank you. Thank you. Thank you for joining us, and thank you for sharing this valuable survey information and helping us launch the 30 Genetic Answers in 30 Days campaign.
And Dr. Crawford, thank you for having me. And I want to thank you for all the wonderful things you do through PHEN to affect and improve the lives of so many men. And thank you for that.
Thank you. Hello, everyone. Tom.
Hello, back to everyone. Number one, I would like to thank all of our presenters and participants today. You did a wonderful job. We would honored to have you with us. And more also, I want to thank our audience. You know, our audience has stayed with us. We recognize that we're running a little long today. This was a pack-filled agenda, and we had some great presentations. I think that we benefited greatly. I think our patients feel that way because many of them are still here. Now, one of the things that we did not do as of yet was have our question and answer period. So what we'd like to do is to take some time to answer questions from the audience. And again, we recognize that we're a little long, Dr. Crawford, but we're going to work through this. We're going to make it work. So so if we have any questions, we would certainly entertain them at this point. In fact, I do see a couple of questions that we let's see. I was seeing one question and I think it disappeared. There's some questions on diet, but we didn't discuss diet today. We will do that at some other time. So I'm going to hold that question to another time. There was some question on PSMA and really what that was about. I don't know whether we have our presenter here that might be able to answer that. Anne-Marie,
Yep.
could you address that, please?
Yeah, I can answer that quickly. So RHPSMA is an investigational agent that consists of a radiohybrid PSMA, so prostate-specific membrane antigen. It's a targeted receptor ligand which attaches to prostate cancer cells, and it's labeled with the F18 radioisotope, and it's used in PET imaging. It can also be labeled with radioisotopes that serve a therapeutic use. So right now it's under investigation, but it is a new, to answer the question, yes, it is a new receptor ligand, PSMA targeted receptor ligand.
Thank you. Dr. Crawford, I don't see many other questions.
Yeah.
So when you don't see a lot of questions, what that means is that the presenters did an excellent job. They explained things very well as they went along. So again, I want to thank all of you who presented and participated in this program. You made this an outstanding program for our audience. I also want to make sure that everyone knows that this program it has been recorded. It will be available in its entirety on our website at phensummit.org. In fact, you can go to phensummit.org on Friday and you can find this program. So even if you did stay with us the whole time, you may want to go back and revisit some of the presentations made. All of our PHEN network members that were on with us today, I thank you. I want to thank Dr. Jackson Davis. Dr. Davis he mentioned that he was a doctor, but Dr. Davis is also, he's a urologist, and so it was good to have you and your perspective, Dr. Davis. And Dr. Emerson Hall, Rodney Palmer, Dr. Moore out of Duke. It's all certainly Dr. Heath out of Comanus, and Dr. Burchuk out of Dana-Farber. Thank you so much for that great presentation and all of the information that you provided us with today. Fantastic. So at this point.
And Dr. Javieri?
Yes.
Jay and Anne-Marie.
And Dr. Hussein, who was who had to leave early, and certainly Anne-Marie. Thank you again. This has been wonderful. We've enjoyed bringing this to you. Dr. Crawford did a great job. It's always good to see you out front. So thank you.
All right, thank you, Tom. And any questions about the kits, or you can call us or text us or email us.
Absolutely. That 30 for 30 genetic testing program that we are in the process of launching, you will get more information on that. And we certainly would love to have you participate with us in that. So with that, next week, we will have our session 4, which will be our final session for our 17th annual African American Prostate Cancer Disparity Summit. You know, when you think in terms of addressing the disparity, we have looked today at treatments, clinical trials, and early detection in terms of addressing the disparity. Last week, we talked about outreach to the community and building the capacity within the community to get information out about our educational tools and information. In our first session, our first session really dealt with the impact of COVID-19 and looked specifically in depth at telemedicine. But when you look at all of these things, they're all really important when it comes to the disparity. But there's also another factor. The social determinants of health are also very important when you talk about addressing the disparity. What impact do the social determinants of health really have on the disparity, and how do we address those? So we have some exciting speakers next week, and also the whole area of financial toxicity is critical. So please plan to join us next week for our found session, and one that I'm sure that you will enjoy and benefit from. And with that, I would like to say again to our audience, thank you. I would like to say to our presenters one last time, thank you. And we are now signing off on session 3 of our summit. Thank you.
Thank you.
Good night.
Good night.